Hello, everybody. We'll get started here in a minute. Wanted to give everybody a chance to sign on. But welcome. I'm Dave Inbody. I'm the CCO Operations Manager, and said we'll get started here in a minute. Good morning. This is the CCO Contracts and Compliance Work Group. I'm Dave Inbody, CCO Operations Manager for OHA. And today we're going to spend the bulk of our time focusing on some of the potential significant contract changes for 2023. Before we get started, I just had a couple of quick announcements. The first is as it relates to the behavioral health policies and procedures. We sent out a memo last week letting you know that the behavioral health policies and procedures will still be due on March 25th, but for the IABHT policies and procedures, we're providing an extension of a month. So hopefully that's going to be helpful. When we had reviewed the 2021 policy and procedure submissions, it appeared that that IABHT was one area where all of the CCOs had some findings, and that there seemed to be the bulk of the issues rested with that. So we wanted to give more time. But for the others, it seemed like for the most part, the CCOs did a pretty good job in 2021. But please reach out if you're having some challenges with that. But I think that should work out pretty well. The other thing I wanted to mention, and this is more of a heads up, I don't know that there's anything that you need to think about right now, but you may want to be aware of, is we did get a notification from the Secretary of State's office that they will be doing an audit, and it's going to be focusing on PBM oversight. So what that means exactly, we're not sure yet, but I suspect that, you know, as the song gets played, you may be asked to dance, but we'll let you know exactly what your role will be. Again, it's still early and we don't have a lot of specifics around it, but it seemed like something that would be worth sharing with you because, again, there may be a point when you may be asked to participate in that. The last thing is I wanted to turn it over to Mary Durant to give you an update as it relates to long COVID. Mary, are you with us?
I am.
Okay, I'll turn it over to you.
Great. So I just wanted to alert everyone, you may be aware because of a conversation that happened at QHawk, but we will be sending out to each CCO a list of claims and counterclaims that you have sent in that relate to long COVID conditions where either the diagnosis code was in the primary spot and should not have been, or that the claim was denied for an HSC edit of being below the line or not paired. Under CMS guidance, each of us on the fee-for-service side and you on the coordinated care side, need to look at those to determine if you should work with your provider on the coding for the diagnosis code spot, or review for medical appropriateness on the below the line or not paired issue. So we'll be sending those out to you with the information that came from CMS so you can look at those. It begins with claims back to 10/22 of 21 dates of service. So there will be a list. We don't always know exactly who to send these lists to, so I'll probably be casting a wide net at each of the CCOs to determine who this list should come to. So if you have any preferences on who the list of claims for review should come to, you're welcome to send that information to me. My email is mary.durant, Durrant, no middle initial. But if not, then I'll be reaching out to you at the CCO with that information. And that's all I had.
Thank you, Mary. Now we'll jump into the main part of the meeting. Again, as mentioned, this meeting is to focus on significant changes that are proposed for the 2023 CCO contract. And our focus today is the first of 3 such meetings. This one is for all those potential changes, significant changes that are not financial and not behavior health oriented. We'll be having a meeting at the rates work group for the financial and at our next Ops Collaborative meeting in early April for the behavior health. But we'll be focusing on everything else today. So some of the topics that we're going to cover, subcontract requirements, and this is a proposal that came from CCOs in 2022 that we didn't make any changes to last year, but felt like it was important enough to bring back this year for discussion. And then the other areas that have been proposed for changes relate to community birth, care coordination to overturn denials, the Indian healthcare providers payments, and requiring mail order pharmacy options. So just to give you a sense of the orientation here, and I'll also ask Cheryl to weigh in on this. Our thought is that we'll have the topic presented, provide you with some basic information, and then leave time for us to have a discussion. And mainly what we're looking for is what the level of interest in terms of the CCOs. Is it something that you see as a positive change? Is it something that you have concerns about and express those concerns? Are there changes that you might want to see, or some subtle alterations that would make this more palatable to you? But as I said, we'll go through this process in the hopes of getting to a place where we have some level of support for where we're headed with the contract. And just to let you know, from here, we'll take the information that's shared here, and it'll be presented to OHA executive leadership for a decision related to whether to put it in the contract or not. So I think the input that we get today is going to be very valuable to that process. So with that, I'll see, Cheryl, if you have any additional comments you wanted to add before we get started.
Thanks, Dave. I think you've covered all the main points I was going to make. I would just emphasize that during the approval consideration presentations that the subject matter experts will do internally following the CCO meetings, they'll be expected to describe the CCO feedback and what concerns CCOs had about the approved change or the proposed change. And then that information will go into the final decision whether or not to approve the change to be in the 23 contract. And timing wise, that final leadership decision making, that's going to be happening in meetings beginning in April and going into the first half of May. We might even have some on their schedule at the end of this month, wanting to get all of these proposed changes through the approval consideration process by mid-May so that we can focus on the contract writing, and OAFA needs to know which ones are approved to finalize the rate development work. So I think that's all I would add. And then I think we have the first of our 5 presenters is Brad Lucas from Care Oregon, representing CPCCO and JCC. And so with that, we will hand off to Brad. It looks like you're on mute still, Brad. 5-star 6.
Is that better?
Yes.
Yes.
Okay. So sorry about that. Hi, everyone. I'm Brad Lucas, Regulatory Manager for CARE Oregon. I've been managing the delegation / subcontractor oversight team for 3.5 years. I'm going to cover two things in my presentation: annual reviews and readiness reviews. So the presentation will be divided into two. And the subtitle is Effective Use of Resources in Risk Management. It actually should have been Effective Use of Resources through Risk-Based Oversight. And what we mean by that is, all the CCOs want to have effective oversight of their subcontractors, but we live in a world of finite resources. So the question is how to balance those two, how to have effective use of effective oversight while living in this world of finite resources. And our proposal is to view it through a lens of risk management, which will become clear as I move through the presentation, what that means in more concrete detail. So next slide, please. And if people could go on mute, I hear a little bit of an echo in the background. Before I dive in, just a little bit of context. The reason why CARE Oregon is sensitive to these matters is because we run both a Medicare and Medicaid program. So as I go through the presentation, you'll see some intersections between Medicare and Medicaid. But basically, for this topic of annual reviews, annual subcontractor performance reports, pretty straightforward. CCO contract requires annual reviews of subcontractors, does not expressly authorize a risk-based approach. Next slide, please. So what we're proposing is basically that the CCO contract would allow a risk-based approach to subcontractor audits rather than mandating strict annual review requirements or particular scoping requirements in every case. Concretely, what this would look like or potentially mean is if you have a high-performing subcontractor, one that's undergone multiple compliance reviews, has a stellar track record of compliance, maybe has a robust business owner oversight to go along with it, that the CCO contract would authorize possibly deferring the subcontractor for a year, their audit, maybe limiting the scoping requirements for the audit, or potentially limiting the types of evidence, or as a reducing the burden of evidence that could be submitted to satisfy the audit. Next slide, please. So we really see three benefits to this. One is just alignment with Medicare. Medicare guidance in the Medicare Managed Care Manual actually has language that authorizes this type of approach. I'll read it for you. It says, when a sponsor has a large number of first-tier entities, making it impractical and or cost prohibitive to monitor or audit all first-tier entities for all compliance program requirements, the sponsor may perform a risk assessment to identify its highest risk first-tier entities, then select a reasonable number of first-tier entities to audit from the highest risk groups. So number one, that type of language would bring it in line with Medicare. It's also an example of a concrete example of the type of language that may be appropriate in this case. So number two, the benefit of taking this risk management approach is that resources can be directed to higher risk areas with more clarity and confidence, rather than a scenario where the CCOs are interpreting the contract to require comprehensive reviews every year. And then the third benefit is administrative efficiency. When you're directing resources to where they're truly needed, you can have effective oversight with fewer resources. You truly don't need to double your team or triple your team because you're using them in the most appropriate way possible. So that is basically risk management when it comes to the annual reviews. And I'll move on to the second part of the presentation, which is readiness reviews. So next slide, please. So there are some parallels here, and in addition, some kind of unique issues that are just relating to readiness review. The parallel is that the CCO requires an annual readiness review for subcontractors, just like an annual compliance review, except, and this is new for this year, where a prior Medicare readiness review already exists. However, in a different part of the subcontract requirement section, this is paragraph 8EI, the CCO contract appears to authorize using prior non-Medicare readiness reviews. So the baseline requirement is in paragraph 4. This other reference to readiness reviews is in paragraph 8. It comes in the context of the subcontractor and delegated work report when you're attesting to the readiness review. So basically, there's some discrepancy in terms of what prior reviews you can use between those two sections. And then lastly, HSAG informed Care Oregon last year during our CMR audit that per OHA, you can use prior readiness reviews, but only when you're operating under the same contract. HSAG's initial reaction when the readiness review issue came up was that, hey, if you have a readiness review on file, you're good to go. They brought it back to OHA, and OHA said, yes, generally, but if you're signing a new agreement, we want you to do another readiness review. Okay, next slide, please. So like I said, a couple of different things going up. I'm hoping to kind of tie it together with the proposals here. So first proposal is just bringing those two contract sections into alignment, presumably to clarify that both Medicaid and Medicare reviews, readiness reviews can be used to satisfy the readiness review requirement. That is prior Medicare and Medicaid readiness reviews. Secondly, we would ask that the CCO contract broaden the types of reviews that can be used, prior reviews that can be used to satisfy the readiness review requirement, to include compliance reviews. The idea here is not that we don't want to get stuck on labels, that the principle is if you have a prior review, it's recent, it speaks to the scope of work, and most importantly, it gives you assurance of readiness, that we shouldn't be too concerned whether the review came out of a designated readiness review process or that prior review came out of a compliance, something designated as a compliance review process. And then thirdly, what we would ask is that really that the CCO contract focus more on the scope of work and not on whether a new contract is signed. Now that actually isn't in the contract, but that's kind of the current state of guidance from OHA. And I'll talk about the benefits of doing that in the next slide. So next slide, please. So the rationale for these proposals, which is essentially being able to use prior Medicaid and Medicare reviews and broadening the types of reviews that can be used to satisfy the readiness review requirement. The first benefit is just contract alignment, making sure there's no discrepancy between paragraphs 4 and paragraphs 8. Number 2, it's removing redundancy. That's where the title of this part of the presentation comes from. So there's two types of redundancy here potentially in play. One is doing a readiness review when you have an adequate prior review and not needing to do that new readiness review because you have that adequate prior review. And then secondly, avoiding having to do an annual compliance review and a readiness review when you already have a prior review that satisfies the readiness review requirement. The administrative efficiency of not duplicating those review efforts, I think, is pretty straightforward. So I'll just kind of pass on describing that in detail. And then finally, the argument here would be that it completes the CCO contract evolution. OHA put in this requirement for readiness review, very understandable, great intention behind it. And then this year they said, you can use a prior Medicare review. So they're clearly seeing that there's some efficiencies to be gained by leaning on prior reviews. And so what we're asking is to take that efficiency rationale and just broaden it and apply it more broadly. So basically the principle is if you have a review, whether it's a readiness review or a compliance review, whether it's Medicaid or Medicare, and it speaks to the scope of work, you should be authorized to use that. And most importantly, to one thing, last point, and then I'll take questions. This topic of whether a new agreement should trigger a readiness review. The CCOs may sign new agreements with their subcontractors, but it's really for business reasons to retain business flexibility, so they're not locked into long-term contracts. That doesn't mean the scope of work changes in any significant degree. So that's really kind of an administrative inefficiency, that if a new contract signed and the scope of work hasn't changed and you have a readiness review on file, that you then are required to go do another review and potentially an annual compliance review on top of it. So we'd like clarity that, actually it's the scope of work that matters and not whether a new agreement has been signed. And that's it. I'll take questions. And I'm sorry, when I went on, had the mute issues, I may have forgot to mention that I am joined here by Chris Zorn, our Vice President of Audit and Compliance, and Monica Martinez, our Director of Legal Affairs, who might chime in as well during this part of the presentation.
Great. Thank you, Brad. I really appreciate that. One clarification for you, or maybe it's more just your input on you had, when you were speaking about the subcontractor reviews. You had said that as a proposal to focus more on a risk-based approach in terms of, and the way I think about it is setting priority on which subcontractors to focus on, and then focusing on those. Any thoughts about what that risk-based approach might look like, or any suggestions there?
Yeah, I think what it is essentially just adding, I think the language could be crafted in different ways, but it's essentially just giving the CCOs confidence and clarity that a risk-based approach is approved by OHA rather than strictly adhering to comprehensive reviews for all subcontractors. So I'd probably wait to kind of hammer out the details if the proposal goes forward, but it would be similar maybe to the Medicare language that I read, which I'm happy to read again. But yeah, I think it could go in the wording could go in a couple of different directions, but it's getting away from the idea that what the contract is requiring is comprehensive reviews for all subcontractors, that there is leeway to say, this subcontractor has been doing great, high confidence that there's not a lot of compliance gaps there. Let's direct the resources to somewhere else.
David, this is Chris. I suppose when I think about risk-based auditing, in my experience, you're generally looking at the subcontractor in terms of what do they do, sort of the relative importance of that, and that's scored. You look at their performance for metrics, you look at how, I think in many of these cases, we know these subcontractors very well. And so it's a combination of monitoring and questionnaires that create risk scores. And we essentially would use that kind of a rubric to kind of pick who they are. We could use a number of different sources, but I think that's what it essentially means for us. It's really about doing more with the limited resources that we have.
Great, I appreciate that. Thank you. Cheryl, did you have a question?
Yeah, I just wanted to clarify a quick point. So Brad and Chris, so the proposed change regarding risk-based approach is essentially to make it permitted, but a CCO could, in theory, choose to have a more rigorous process. But if a CCO does choose it, then they could go with risk-based. And I'm asking it that way because ultimately the CCO is still responsible for all their subcontractors, same as if the CCO itself were doing the work. So it basically lets them choose risk-based, or they could stick with something more rigorous if they wanted to. So am I understanding it correctly?
You are. That's an important point. And in no way does this proposal relieve the CCOs of its responsibility. As a matter of fact, I would say that if a CCO adopts a risk-based approach, it has to be a sound risk-based approach. And, with a risk-based approach, you have to clearly identify what you're going to do and understand what gaps you might have. So you're correct, Cheryl, absolutely.
Yeah. And I can add to that
Chris.
too, that if you look at the Medicare language, it mentions this risk-based approach specifically when it's, quote, impractical and or cost prohibitive for the organization to comprehensively review all their subcontractors. So if that weren't the case, if a CCO was in a position where it was practical and it wasn't cost prohibitive to do that sort of comprehensive approach, then you could build that language in just like Medicare does.
Wanted to reach out and see if there are any questions or comments from CCOs. And I'd also be interested, you may not have questions or comments, but if you have an opinion one way or the other, do you support this idea or do you have concerns about this idea? I'd be interested, and you can put that in the text if you'd like. We have a few more minutes on this topic, but I would be interested if there are any comments or questions from CCOs. Alex, you got your hand raised. Do you have a question or comment?
Hi, yes, this is Alex Covington with Health Share of Oregon. I just had a comment that I also would think that this risk-based approach would be a much better approach for managing resources, just because, there's only a finite amount of money that we have as CCOs. And this would allow us to really pin down, what are each organization's greatest risks with subcontractors and really be able to focus our resources more on those audit approaches rather than focusing on things that, if we were able to show that they aren't a high risk for our organization, then there's no need to do an annual review every year of the same thing over and over.
I appreciate that, Alex. It looks like we're getting a lot of indications of support from other CCOs. In the last few minutes we have here, any concerns or comments, questions, or things that we should consider before carrying this forward for further consideration?
This is Tara from Pacific Source. Brad, I had a question. Had we thought about sort of mirroring what HSAG does for OHA, how they look at certain aspects that are delegated? Like we would audit all of the, like a primary function of all of the subcontractors, and it'd be almost like on a cycle, like every 3 years, we would evaluate our subcontractors instead of like focusing on who we audit, but we would touch all of them, but not have to do all delegated functions every year.
Yeah, my initial response is that would be part of the risk-based approach. The CCOs would have the flexibility to determine the risk areas and where they want to put the resources in.
Okay, so it wasn't just specific to which providers or which subcontractors we would audit that year. It could also be the functions that we audit.
Yes.
Okay, thanks for clarifying.
Looks like we've come to the end of our time on this topic. I really do appreciate it, Brad and Chris, for bringing this forward and for explaining it and sharing it with us. Like I said, this is something, and it appears that there's pretty universal support from CCOs to this approach, and we'll convey that moving forward. So thank you, and we'll definitely keep you posted on where this goes, and I'm sure there'll be opportunities for more input on this from the CCO. So thank you.
Thanks so much for having us. Thank you.
Thank you.
Our next topic is on community birth opt-in, and we have Diane Queering with us to lead this discussion. Diane, are you with us?
Good morning.
There she is.
Is my audio okay?
Yeah, we can hear you. Thanks, Diane.
Okay, super. Good morning. Thank you for the opportunity to bring forward this concept. My name is Diane Queering, and I'm with the Medicaid Programs Unit within Health Systems Division. And I have oversight of medical surgical program areas, which includes
births that take place. Specifically, we're talking about births that take place that are planned in a setting other than hospitals, so in the community. Next slide, please. So what we're bringing forward today is a proposal to have a voluntary amendment opt-in that would be effective July 1st of 2023 that would allow CCOs to be able to cover planned community birth services for all of its qualifying enrolled members who elect that option. Currently, we carve this service out of the coverage in the contract. What we're proposing is that for those members who are electing to establish care with a community birth provider that is not in the CCO's network, we would continue with that carve-out, with the current carve-out process. But we do know that some CCOs do have some contracts with providers who provide this services. Yes, and I see Cheryl put in a good comment in the notes in the chat that when I talk about community birth in the contract language, it's called out of hospital birth, OOHB. We're kind of moving our language to planned community birth. This proposed change would last for 18 months. So to the end of the current contract year, which would be the end of calendar year 2024. OHA will continue to process all prior authorization requests for a community birth, just as we are now. And then as we identify that if a member is selecting a community birth provider who is enrolled with a or contracted with a CCO, we would transfer that prior authorization work over to the CCO to continue that sort of concurrent review. For those who may not be familiar, of course, during the course of a pregnancy, there's various tests and evaluations that happen over the course of the pregnancy, and that sort of concurrent prior authorization review allows OHA, and in this case, CCOs, to assure that the pregnancy is continued to be considered low risk and appropriate for a community birth setting. Next slide. So again, just a little bit of history. Why are we thinking about this? It's because, you know, back at the beginning of the 2021 contract year, we moved from completely disenrolling those members who were electing a community birth. We were disenrolling them entirely from their CCO and moving them into a fee-for-service open card coverage. But that often resulted in sort of a disruption of their care. Members maybe, you know, had other physical or behavioral health needs, and all of a sudden they needed to find different providers, and so we decided to move towards that, carving out just the community birth piece. Since that time, there has been some interest by CCOs to include this coverage for a community birth, planned community birth, as part of their overall care coordination. And so this proposed change would now allow those CCOs who are interested in this to opt in for this coverage. Next slide. Again, you know, kind of the goal of this is so that we can improve continuity of care for CCO members for all of their physical health care needs. We also know that in terms of from a health equity lens, there certainly are some priority populations who seek a planned community birth, and this carving out can lead disruption of care for their other physical health care needs and just care coordination in general. So this move would also kind of support our efforts to begin moving towards utilizing CCO system to operationalize this, the Oregon Medicaid delivery of healthcare. So it's just another component of the healthcare needs. And this would be sort of an interim step with the intent that we would require planned community birth coverage for all CCOs as part of the new contract period starting in 2025. In terms of the question about how does this impact deliverables, this would have no impact on CCO contract deliverables or reporting requirements. And next slide. And so I'll open up to questions, specifically a couple of things that we're interested in hearing is, we currently share files with CCOs regarding their members who are currently seeking prior authorization, and just want to take this opportunity to kind of check in how is that sharing of files going from the CCO's perspective. Are there any concerns about the communication and coordination between OHA and CCOs? Again, as I talked about, if in this proposal, when a member is selecting a community birth provider who is contracted with a CCO, that sort of coordination of passing that case over to the CCO to continue that concurrent authorization review, and then interested in hearing if there are any barriers to providing care coordination for enrolled members selecting a community birth and how CCOs might address those barriers. I think I have a few questions on the next slide and then I'll pause. So again, just sort of broadly, what kind of concerns do CCOs have regarding this sort of proposal of, and in contracting with community birth providers in general? And based upon what we talked today, maybe at the end, if you would be interested in considering opting in for this amendment. Okay, I'm looking at the chat. 2 questions from Josh, which CCOs requested this. Let's see, I have some notes about that. I think there was interest from HealthShare and Providence Health Plan. Those are the ones that come top of mind. In terms of what medical directors say about this change, we haven't taken this to the medical directors. I think, what I recall medical directors having some concerns about were about some of the birth providers. Again, this proposal would allow enrolled CCO members who are selecting a community birth provider who is not enrolled in a CCO or not contracted with a CCO, that member could continue care with that selected provider, and we would again just continue to follow that as a carve out and cover it under fee for service. Okay, will there be credentialing criteria provided? I think, right now, Holly, we have, of course, enrollment of community birth providers in our fee-for-service program. That will not change. And certainly, I would think it would be up to the CCOs to establish whatever enrollment criteria you have for your contracted providers. Adjustments to rates to allow for higher risk. I think we would take a look at that. I think that's really a question for our actuarial staff. And I appreciate Cheryl's comment. Remember, this is a proposed change. So again, these are all things that we would want to take a look at, and just see if the idea is something we want to move forward.
Do you have any other questions or comments for Diane? Okay. Thank you, Diane. I guess the other thing, I guess before we move on, I wanted to just send out a request. CCOs, if you want to or have feelings, good or bad, about this proposal, please put it in the chat so that we can have that information to share when we do take it before executives. Actually, it looks like I'm looking to see if there are additional questions or just comments here in the chat. Comments. Okay. Well, again, if you have thoughts or positive or negative support or not for this approach, please put it in the chat. And in the meantime, we'll move on to our next item, which is care coordination for overturned denials. And for this topic, I'm going to turn it over to Jaime Nino with this.
Hi, Dave. Thank you.
Yeah, thanks for
hello,
joining.
everybody. So my name is Jaime Nino, for those that I haven't met yet, and I'm with the Oregon Health Authority Ombuds Program, and we work directly with members that reach our office, usually once they've exhausted either the grievance system process or the appeal process, or just haven't found the right place or right door to knock on to get help, or really to help navigate the systems, as we all know that the medical insurance world tends to create, these big systems that are hard to navigate. One place where we saw an opportunity is providing care coordination for overturned denials. Next slide, please. I will preface that recently there was a care coordination collaborative that was started by the Transformation Center in January, and they're having this collaborative meets monthly to discuss how care coordination is being provided, what are the current requirements, and share ideas amongst CCOs on, each CCO does some things a little bit differently and what works and what doesn't work. Way before this collaborative was started, we had heard, or what had kind of trickled through the agency from different CCOs, is how can we best, when and how should we best provide care coordination? Not that the work, folks don't know how to do the work, but there's certain situations where care coordination could be more appropriate. And again, this is just to highlight, because we've received those questions, where we could put language in the contract that would allow for this and kind of give some guidance and direction and standardize across multiple CCOs. So currently, the requirement is the 72 hours after an appeal, after an overturned, the language is reversed appeal or contested case hearing decision. The language only requires that the contractor authorize or provide the disputed service promptly and as expeditiously as the member's health condition requires, but no later than 72 hours. So when we stop there, let me go through the slides first. So that's the requirement in the current language. The change would require, or the added language would be, to connect the members with a CCO care coordinator and require the CCOs to provide a notice. So we're not saying that folks or CCOs aren't doing this already. Again, this is just give somewhere to point to give direction when questions are asked. How do we do this? How what is the requirement? can you give us some direction? Next slide, please. Why the need to change it for this contract restatement? Again, it allows OHA to provide some guidance when questions arise. It standardizes the process across multiple CCOs. And most importantly, it allows timely access to services for members. A lot of times, by the time someone has received an overturned decision on appeal or contested case hearing, all the way through the contested case hearing process, at a minimum, that person has gone out without services or without the service that's been requested for anywhere from 4 to 8 weeks at a minimum. It could be longer, depending on how long it took them to file the appeal and how long the contested case hearing process took. So that's part of why the 72 hours is in there. It's, can we get this approval in place as soon as possible? And can services be provided as soon as possible? Next slide, please. As far as impact on deliverables, I don't foresee a change in deliverables. As I understand, CCOs already report on appeal outcomes and overturned decisions. But if that's a concern, that's definitely something we can look into. And the next slide, please. And just a few questions for CCOs as you consider this change. How could this change help support health equity? Would there be any barriers to implementation? And what does current process look like to ensure services are delivered upon a reversed appeal or hearing? So really the question is, what are you doing now? And would this be any different than what you're doing? As I mentioned, and in my experience, some CCOs already do this. The first thing is some already send a notice saying your services have been overturned on appeal or hearing. Here is your approval. And then some CCOs already connect the member to a care coordinator to ensure that appointments are set up or scheduled, or if necessary, providers are found to provide the services, and kind of gets the ball rolling so that they have the services as soon as possible. That's what I had to share with folks. If anybody has questions.
Any questions or comments for Jaime? Deanne, go ahead.
Good morning, Deanne Karp, Behavioral Health Director with YCCO. And, your first question catches my attention of how would this change help support health equity? And honestly, my immediate reaction is, well, it's not going to. But, taking a deep breath here, I think my feedback is more around one size fits all doesn't tend to help. And I think that it feels like over the last couple years, care coordination has been, seems to be treated like this magic bullet or magic pill. That's a little less aggressive there. To fix things, and we create these subcategories that we're just going to apply this to. And I feel like maybe we're going with overkill for this one method. And so I guess that's where I'm just not understanding how care coordination for everybody who had to go through an appeal process is actually going to impact the situation when, following an overturn of an appeal, the services get started. What else do you think's going to happen that's makes it sort of the cost benefit ratio pencil out?
Thank you. That's a good call out. So I can describe one situation that was kind of, and it could be an extreme situation. And I totally understand that it one size fits all. I think my intent with bringing this proposal is, again, CCOs are already sending out notices, and CCOs are already plugging folks into care coordination where appropriate. So the ask to include the language here is to take a look at, you're already doing these things. Would this benefit the member to go through care coordination? And have that review, because my understanding is care coordination, when someone has a referral for a care coordinator, it kind of goes through a review. You know, what is the need? How much help do they need? And it could be as easily as, hey, we found a provider that can provide this service. The appointment is set up. We've connected you with the provider. You're set to go. Or does this person need ADA accommodations? Does this person need language services? Do they need special or any non-emergency medical transportation? Things of that nature. And those are the ones that we've seen kind of fall in the cracks or fall through the cracks. There was one case where um, before the administrative hearing, the CCO approved uh, extensive dental services for an autistic older teenage child. And the family didn't speak English. So they had the approval in hand, but because appointments weren't made and language access services weren't provided, uh, it was a year later before the mom came back and said, I've never received these services. My son still needs these services. So that's just, again, an extreme example of where, had they been plugged into care coordination, and care coordination, you guys do what you do with care coordination in the reviews, as far as what level of care coordination they need, they wouldn't have fallen through that gap. So I'm hoping that it's not asking too much of the CCOs. It's just highlighting a great place where these services could be considered for best outcome.
Hi, May. It's Shelley from JCC Columbia Pacific CCO. How are you?
Hi.
I guess my question would be, it would seem to me that to require this for every overturned appeal would be a huge administrative burden, and require a huge increase in staffing. I think Carissa put a comment in the chat. I know at least for my teams that do this work, we're very well versed at when a member might need help navigating the system and getting help with an overturned appeal. But to make it mandatory for every single member, I think is an administrative burden, and it seems duplicative to put language there. We're already required by rule to submit notice to member and provider, so why does it need to? I don't understand the point of putting it in the care coordination section. So maybe you could explain that, please.
That was suggested by somebody outside of my team, that we include if we were going to ask for the change in the language to require care coordination. But the only thing I can respond to that right now is it's kind of the same. It just highlights where, when asked, how do we do this, or what do we need to do? Not that we get that question all the time, but it answers that question. What do we need to do? Provide services or authorize services within 72 hours. Make sure you get a notice out, and if make sure or ensure that a review for care coordination has been done, to identify any special needs. That's kind of a 30,000-foot level explanation, but that's, I think, the intent behind this.
Cynthia, did you have a question or a comment?
Yes, can you hear me, Dave?
I can hear you. Go ahead.
Okay, great. Well, sometimes I'm off site, so sometimes my remote doesn't work. So I want you to look at what Dr. Burnett wrote in the chat box, because many of our denials are a result of not having sufficient information at the time of decision making. And just to support what was stated just a few minutes ago, it would tie up actually care coordination services that were needed to help members, in other areas of their care. So I just, I don't know how the language would read, but if you look at how she verbalized that, I think this is really an area that needs to be reviewed carefully so that we don't take resources away from people that really need that help. It would be I think it would create a bottleneck of sorts.
That's a good point. And yes, I like Kelly's comment. Just a little bit there, just a comment of my own on Kelly's comment, just something to think about. Are we, because it happens with fee for service as well, are we overturning on appeal when we don't have enough documentation, or are we reviewing a brand new request for the same service and approving the new request, which wouldn't be considered an overturned appeal? Just something to maybe consider and look at if that's, you know, what truly is an overturned appeal, and how often is it happening? And I see other people
Jaime,
have.
it's Shelley. I think overturn rates run fairly high, 30 to 40, 50% commonly because of what Kelly Burnett pointed out. And we really monitor and track that. And I know we've put some measures into place to try to improve that on the front end of the prior authorization process, but it's still the reality that providers often don't submit what's needed.
Cheryl, did you have a comment?
Yeah, thank you, Dave. So going back to Jaime's original concern and premise, so thinking about the, albeit extreme example that he shared, so there's certainly less extreme examples that are still in the same realm of the denial got overturned, the member has been without that service for a period of time, and what if they have barriers to help them access the care? So basically, then what changes could be made that would minimize or even prevent the situation he described from ever happening? And I absolutely appreciate that CCOs have very robust processes, but things do still happen. And what Jaime described is a pretty awful situation to, you know, have a year later the family still not have the service for their child with autism and doesn't speak English. So what's a different solution that potentially gets at the same concern if this particular proposal isn't the preferred or best approach?
Thank you, Cheryl. You know, we're coming to the end of the time. I see that Jim and Stick have their hands up. I'll have them go ahead and make their comments or ask their questions, and then we'll have to move on to the next. So if there are any other comments or questions that people have, please put them in the chat. But Jim, if you want to go ahead.
Thanks, Dave. And Jaime, I appreciate the need to catch these extreme cases. However, some of the comments that were already put in there, I want to just go on record to support, is that when you look at how the CCOs are managing the care coordination for these populations, chances are many of these appeals have been in high scrutiny and or have made it to high level medical director review, or even many instances, chief medical officers at this point. And I think there needs to be some trust given to the CCOs to allow their processes to stay in place and be engaged, and not put one more administrative process in place that's going to potentially take away from other administrative needs that are coming in that are new. So I don't disagree with the concept. I know what you're trying to say, but I think there might be just a different way to enforce that along the process. And if we were to look at the examples, I'd bet that most of these cases, with the exception of the extreme that you just pointed out, because that happens, things do fall through the cracks. Most of these cases are on somebody's radar and have been coordinated, and they're getting all the things that they need out there. And so that could be a discussion that we talk about upstream rather than downstream at this point in this juncture. And I'll just say from our team, our care coordination teams are maxed to the kilt with new. And we have people that are churning in and out on a regular basis, and we're doing everything we possibly can to stay up with new and de-escalate the already current ones that are complicated in our care coordination and our ICC models. So I totally support the administrative side this could be a burden, but would like to explore conversations as to how do we meet your extra vigilance in this space to make sure that some of these things don't fall through the cracks. I hope that makes sense. And I appreciate the comments to this point.
It does. Thank you.
Stick, comment or question?
It took me a second to come off mute there. Sorry. Yeah, it's just a comment statement. I'm not really sure how to say that, but I mean, I really appreciate this concept. I do think it does kind of miss an important element here and a mark in our processes that I really think the state's trying to support through the health equity plan. And that's the Real D and SOGI implementation. And that's, really looking at this in terms of after the denial is overturned, who's getting connected to those services. And then also remembering that the majority of these are appealed by the member. So, are those appeal rates, I guess what would be more important to be looking at is, are your appeal rates based upon Real D? Are they not occurring for groups that should be occurring these services? The under and overutilization that we should be looking at in that way. I do fear that doing this broad rule would then take away from resources for CCOs to be addressing administrative processes that could be more accessible to those that may have limited English speaking or reading needs, or maybe literacy competencies, things like that, and really addressing their process to hyper focus on these communities and be getting that community input. But I do really appreciate the thought and the state coming forward with something like this.
Thank you. And I think Cheryl hit the nail on the head. It was, an idea we wanted to float, and if not this, just highlighting where in our current processes might we do a little bit better to catch these types of situations or cases. And again, if not here, again, the care coordination collaborative being put on by the Transformation Center is kind of weeding some of these things out. As they've only had 3. We're in March, and they're planned once a month for the rest of the year. So if some suggestions can be taken back to that collaborative for how to address kind of the question that's been brought up with this suggestion in the change, we'd gladly receive them there as well. Thank you for the opportunity to share this with you.
Thank you, Jaime, for joining us, and thank you for the input. And like I said, if you have any additional comments, please put them in the chat. A lot of good points brought up on this one. Appreciate it. Our next topic for today is the Indian health care provider payments. And for this, I'll turn it over to Jason Steiner. Jason, are you with us? I can see you, but I can't hear you, Jason. We're still unable to hear you.
It shows he's on mute.
Hello?
Yeah, Jason, we may need you to try and call back in. I'm not sure why we're not able to get you unmuted here. Sorry about that.
You might want to unmute yourself. I muted everyone to try to unmute Jason.
Hello, are you able to hear me?
Yes.
Ah, there we go. All right. Sorry about that. Just talking away, and I don't think anybody was hearing me. Hopefully we'll be able to correct this. Just give us a minute here. that Dee?
This is me. This is Dee.
Great. Do you want to go ahead and go? We'll hopefully we'll be able to work out the issues we were having with Jason in the interim. But if you wouldn't mind going now, I'd appreciate it.
I'd be happy to. Is somebody else running the slides, or do you need me to share that?
Yeah, we can run the slides for you.
Okay. Okay, great. Thanks everyone for your patience, for still sticking around with us. I appreciate it. I'm sure everybody else does too. I'll just wait for them to show up, the slides. I think I have them ready too, so I could probably share my screen if that's better. This is what happens. Cheryl just sent an email to the presenters, or a message to the presenters not long ago saying that we were ahead of schedule. So I think that's probably what doomed us. Okay. So I'm not even sure who all is on this call. I'm sure some of you I do know, some of you I don't. But my name is Deborah Weston. I go by Dee. I'm the Pharmacy Program Policy Advisor, and I focus mainly on Medicaid programs. And the slide just disappeared from me.
I can see your slides.
Oh, you can? Okay, because I cannot. I hope others can see it. Screen is blank for me.
We're on a slide that says description of proposed change.
Okay. I will you'll just have to let me know. Okay, so I'm going to look at it over here. So I apologize for not making eye contact at the camera. I think this is a fairly simple request, but that's why I'm presenting it. Maybe it's not so simple. The proposal is to require mail order pharmacy as an option. And the description is that this would require all CCOs to provide an optional access to general mail order pharmacy services. This would apply to at least to non-specialty chronic medications other than controlled substances. So it's relatively narrow in its application, or actually, it would apply to most medications, I should say. It would require CCOs to notify members of this available service. It requires CCOs to also notify OHA annually of the terms and conditions for this access, and again within 5 days of any change. And it would prohibit CCOs from requiring mail order pharmacy or requiring members to opt out. And by that, I mean, so you wouldn't require all CCO members to use mail order pharmacy for their chronic medications, and it wouldn't require them to take some kind of action to opt out. It would have to be something that they would opt into. And ready for the next slide. I'm not sure how these how other presentations have gone, but I'm going to try to do my best to answer the questions as they arise. So feel free to ask. The question was from Jim Slater: would retail mail pharmacy services count, or does it need to be licensed mail order pharmacy? The intent here, and this is something that maybe would be good to pin down, but the intent is for anyone who's interested in receiving mail order pharmacy services to have an easy way to receive them. So it wouldn't require them to work out a plan with their retail pharmacy of choice that they usually go to physically, but it would be something that would be provided. They would maybe contact a central number and then arrange those services. But at the end, there's an opportunity. I'll have some questions and we can kind of go into more detail and back and forth. There's a Nana Ama, thank you. You have a question: with the mail order option, would the state be requiring CCOs to cover for 90-day supplies? And that's not part of what this proposed change would be. It wouldn't have anything to do with day supply. It's just having access to mail order pharmacy. And I know some purveyors of this service, they require 90-day supplies, or they are more interested in promoting 90-day supplies, but that's not contemplated by this proposed change. I'm not sure which slide we're on now. If anybody has advanced it, I'd like to go to the wide.
It reads, why does the change need to be made in 2023?
Thank you. So the reason why the change needs to be made is because we've come to learn that not all CCOs currently support general mail order pharmacy services. This is something that in talking with community members and providers, or Medicaid recipients or HP recipients and providers, they've urged OHA to ensure all CCO members have access to it. I believe it supports equity, especially for individuals in rural areas or who are individuals who are less able to travel. It would have reduced exposure risk for, especially during this COVID period. It was put forward as a strategy to avoid exposure risk for people having to go into a pharmacy. And it could potentially lower administrative costs, improve health outcomes, and reduce the need for non-emergency medical transportation, or NEMT. And it would not impede access through other avenues, such as physical community retail pharmacies. A question from Amy Burns: would the CCO be able to prefer mail order pharmacy? Yes. I mean, this doesn't change CCO's ability to have different networks and so on, and doesn't require you to take all kinds. It just would require the CCO to in some way ensure that all members have access to be able to receive their general chronic medications through the mail if they choose. I hope that answers that question. And on to the next slide is the impact on deliverables. There would be potentially either a entirely new deliverable, or perhaps a change to an existing deliverable, because it would require CCOs to notify OHA annually of the terms and conditions of that access, and again within 5 days of any change. Is somewhat similar in my mind. Existing requirement is that all CCOs provide preferred drug lists and drug prior authorization information on or before January 15th of each contract year and within 5 days of the change. And there I put a citation to the contract. So I don't know if this new deliverable could be tagged on to that element, or it would be just an entirely new one. Open to suggestions for that. And then the final slide are the questions for CCOs. And I would also, I'll go through these, but I will also invite discussion if there are more chatter about the chat. Some of the questions that others have raised. If you'd like to speak more in depth about that, I'd be very happy to do so. The first question I had was, would the proposal require a substantial change to current operations? Looks like Jim, you have your hand up.
Yeah, are you looking for a response to the question?
Yes.
Okay, cool. I'm just helping out. In our case at Care Oregon, it would not. We offer mail order to our Medicaid population and our special needs Medicare population, and have for quite a long time. I do think it creates some other interesting observations that we can talk about, but just to answer your question, there would be no immediate effect on our operations.
Okay, thank you. And I anticipate that to be the case for most of the CCOs. We did a survey, and the Ombuds team did a survey in 2020, and it looked like there were 2 CCOs at that time that did not have a general mail order service. I don't know if that's changed since then, but okay. Amy Burns, looks like you have your hand up. I don't know if you can speak. Amy, I don't know if you're on mute or if we're having more problems with the audio. Um,
We go to the next question and we can come back to Amy.
Sure. And I'll go on also the chat. I think a response from Brandy was Advanced Health offers mail order as well, and benefit structure is similar to the retail. Some with 90-day meds, other for medications. Sorry. So it sounds like for Advanced Health, it also would not be a major change. And then Amy says she's not able to get off mute. So it sounds like we're having another mute problem. Amy, if you could, I don't know if you are able to type up what you were trying to say. We can go from that. I saw, backing up a little bit from Jessica, there was a comment about this is the deliverables approach, and there's some input suggesting it would be ideal to incorporate any new deliverables with existing deliverables, so we do not have more timelines to track. So if there's anyone who has a different view of that, please type it in or speak up. That makes sense to me. I don't know. We'll have to talk with the team though, because that's something that's, I don't receive the deliverables myself, so it's not as of, I don't have any insight into it. Let me see if there's something else. Okay, question, it looks like from Anna. Would including the mail order pharmacy provider in the quarterly DSN provider capacity report be adequate? And I'm not sure I know what all that is. I would say no. I would expect the notification to include how members are able to access this service, mail order pharmacy. Is it something they can call into, who it is, if there is a single provider, and are there limitations on what medications can be received that way, and so on. So I think that, Anna, I think your question was about the reporting mechanism. I think what you proposed probably wouldn't meet the need, or meet the request, I should say. Shauna from Trilliums also says no major change. Sounds like also no major change for Pacific Source. Okay, IHN, no major change. And I think, Nana, I think that actually, I thought IHN was one of the ones from 2020, so things maybe have changed. That's great. That sounds like it wouldn't be a big lift for IHN either. But it would be an operational change for CHA. So that was the other one that I kind of wondered about. So we can talk about how significant that is if you'd like to, or you can follow up. And then Amy, sounds like you, All Care offers mail order through the retail network. If you need to have a separate mail order network, there would be changes to the PBM contracts, rates, et cetera. And I don't know how easy it is or how difficult that would be. I think the overall goal is to have an easy access. Just for a little bit more information, we met with a couple different groups, medical advisory committee, regional health equity committees, and other groups. And a few people said that they didn't know of how they could access mail order. That was something they were interested in. Either they just weren't notified, they didn't know how to access it, or it wasn't available to them through their CCO. So hopefully the goal is so that everybody knows how to access it and has access to it for general mail order pharmacy, and for the OHA to also know. This would have been helpful for us as we were trying to help strategize during the public health emergency. And because we didn't have that information readily available, we had to do an outreach and survey. So it would have been nice to have it, on our fingertips. So I don't know if you have more follow-up with that, Amy. Looks like EOCCO offers mail order pharmacy. Advanced Health includes how to use mail order pharmacy in the member handbook, which is reviewed and approved by OHA without work for a reporting mechanism. I'll kind of defer to Dave Inbody and others, but I think that would be adequate for me. I would just want to have a way to see it. And I assume that this would probably be in the member handbook. And so I think that meets my need, is just to have that detail available somewhere. And it seems like the member handbook is probably where it should be. Brandy, do we only have to have one mail order pharmacy, or does the need to be multiple available to members? I think one is okay. Whatever is preferred, it's just the goal is for the member to have access to someone. In the example in the fee-for-service program, there is only one general mail order pharmacy provider. It's PPS. I think that's who EOCCO also uses, and I think a few other CCOs are also using PPS, Postal Pharmacy Services. And I think that's perfectly fine. And in many ways, it might make it easier, but I defer to you all. Cheryl, yes, for sure in the member handbook is what she would say. Yamhill YCCO does currently offer mail order pharmacy. Thank you, Jill. And it looks, and I do see a couple hands raised. I don't know if everybody's on mute now or if anybody can speak. Jim Slater was able to speak earlier. Jim Gardner, I don't
unmute actually. So yay. Can I ask my question?
Yes, no, is that Nana?
It is.
Okay. Okay, Nana, go for it.
Thank you. You may have already answered based on Amy's question and I just missed it, but in terms of if we have retail that's able to mail out, because what comes to mind is pharmacies will need to be enrolled with Medicaid, and a lot of these mail orders, some of them are out of state, and I don't know their incentive to want to be enrolled with Medicaid in order to fill medications for our IHN members. And so in terms of mail order, perhaps that flexibility of either whether it's a mail order pharmacy designated or a retail that can mail out to give members more option and the flexibility when it comes to getting their medications.
Mm-hmm. Yes, and that might be something that I don't know the details as much about, and may want to talk with the team to give it more thought. I think, again, the main goal is for CCO members to be able to have ready access to this. So there's ideally one number they would call, maybe there's more than one number to request this service. For out of state, you're right, we do have generally the pharmacy needs to be within Oregon. If that's an issue because the CCO would rather not contract with an in-state mail order pharmacy provider, then I think we can talk about what the other options are if they're not already enrolled. I don't know if there are other thoughts on that too. Amy notes that we use PPS as well, but again, in the retail network, even though it used exclusively as a mail order network. I'm not sure if I, sorry, Amy, I'm not sure if I followed that comment, but are there any other comments in line with what Nana was saying about out of state mail order or a retail pharmacy sending out? It might be good for me to have more input on how that would work. How would it work for I guess a brick and mortar retail store to mail out? How would a member access it?
Dee, this is Jim. I could make a quick comment if it would help
Yes.
to expand the input on this subject. I think that through COVID, what we've seen is between federally qualified health centers and retail pharmacies significantly expanding their delivery capabilities and learning through that process to make it easier and easier I wonder if a CCO partnered with a key partner to meet your requirements, right? Where it's a member can go to the CCO website, they can see that somebody is eager, ready, and this is a simple way to contact for these services, and it meets a mail order experience. I would tend to vote for it to be an option, partly because over the years of my experience, both for Medicaid and special needs Medicare, and we've actually notified our members and tried different projects with them, and they've repeatedly given us, and we have a very, very low mail order penetration because they've educated us that they really like their local relationships. They like a human being that they can see, and they're just don't seem to. But I do agree. There's a subset that may want a mail order option, right? But in general, they prefer that local experience. The other thing that we've observed is many of them have significant medication changes, and oftentimes retail is able to handle that 30-day new start change dynamic versus 90-day fill dynamic a little easier than mail sometimes. And so I think it helps with that facilitation and care coordination. So those are just some initial thoughts.
Okay. And I'm getting a message that I need to start kind of wrapping things up. I hear what you're saying, and maybe we could talk some more. I'm not sure what the next steps are for the timeline. We do happen to have a CCO pharmacy directors meeting on April 7th. That might be too late, but I'm certainly open to discussing things more now. I think we've kind of hit the overall goals, and I think it's probably a shared goal for there to be a way for people to receive medications by mail, to know how to receive them by mail. It sounds like there may be more to discuss about how that should be done. If it should be a designated specialty, like a mail order pharmacy, that's what they do, or should it be a retail? Okay, well, I think probably we're coming up on time, and I think Jason needs to take away. I'm going to look through the questions for the CCOs. I think we've covered that. Are you aware of any barriers that will make compliance difficult? And then can you offer any best practices or suggestions? So I will look forward to reading more of the chat that's coming in. Cheryl and Dave, I don't know if you want to take it away, and if you could let me know what the next timeline is for responding to these sorts of issues, I would like to explore them a little bit more.
Dave, Dave, sorry, just before you get in, one last thing on this. Just the one thing that a best practice that would be wonderful here is you make a foundational statement, and we have everybody around the organization follow it. I support the optional side of things, and I also support the ability for us to ensure, all the CCOs to ensure how members have access to these types of benefits. And I think with that simple thing right there, and the fact that we want that either identified in a handbook, and actually that would be the best place, and I'd leave it at that, then now you have oversight, you have understanding, and the options of how the mail order benefit, because it is complex, that's out there, is left up to the CCOs to administer accordingly to their plans as needed. Because as a rural frontier CCO, this is something that we do. This is something we have done, and we do it within the parameters of working within our structures that we feel is most appropriate. And we allow our members to do that. So if you could consider that as we're thinking, and not allow this to be an administrative burden, just a notification process, that would be wonderful. And again, let the handbook be the notification process. We should be in a great space. Thanks.
Okay, thank you.
I appreciate that. No, are you able to hear me?
Yes. Okay. Sorry, Dave.
Yeah, it sounds like we have a path ahead here, which I think is helpful. Obviously, there are some details we're still going to work through, but as was mentioned at the beginning, the main purpose for this meeting is to get you acquainted with some of these proposed changes and identify any big issues. And so I think Dee has some notes moving forward, and I appreciate the input. We're going to give Jason another try here, see if we can get him on the phone. Let's see if this is going to work here. Jason, give it a shot. Looks like we still can't hear you. Well, as a potential workaround, one thing that we're going to try is Cheryl Henning is going to communicate the proposed change, recognizing that she's not the expert on this, Jason is, so he'll be available to chime in through the chat as best we can to make sure that you get the information that you need. But Cheryl, if you wouldn't mind stepping in on the audio side and walking us through this, I'd appreciate it. We still can't hear you, Cheryl. It looks like you're still muted there. I guess we could start. I mean, I can walk through it, recognizing that I'm not as familiar with this as Cheryl, and definitely not Jason, but I'll start to walk through it, and we'll see how this goes. Get the slides back up there for this item. Okay, we need slide number 22. Okay. All right. This item is requirement of CCOs to reimburse Indian healthcare providers at their applicable encounter rates. Description is that the existing CCO contract and federal regulations require CCOs to reimburse IHCPs at the PPS or IHS encounter rate that they would receive if billed fee for service. And so we're moving to clarify CCO contract language to ensure operationalization of this requirement. IHCP encounter rates are clinic specific. There are 16 IHCPs enrolled with OHP. Contract and federal law require OHP and CCOs to reimburse them at their encounter rate, regardless of the status of the contract. So that's in network or out of network. And so what we're seeking is to ensure payment is made to IHCPs at their applicable encounter rates for billed services. The questions we have for the CCOs, Are there any internal operational processes that CCOs will need to coordinate to ensure that they can comply with this? The structure of communication between the CCOs, tribes, and OHA around the implementation. The role of the CCO tribal liaisons in coordinating this effort, and any data requests needed by CCOs. So with that, I'll open it up, see if there are any questions or comments on this particular topic.
Hello, sir. My name is James Craig, and I'm a tribal liaison with Health Share of Oregon. I'm really interested in the role of CCO tribal liaisons in coordinating this effort. Also respecting the Tribal Advisory Council that takes place monthly. I'd like to see how those are aligning and what information is being, given to the tribes versus the CCOs if we're all on the same information level. Thank you.
I'll ask, this may be a little awkward, but I'll ask Jason if you wanted to respond by text. I'd appreciate it. It looks like we also have a couple of questions in the text. Jason's saying that he and Michael Stickler are available to coordinate with the tribal liaisons and with the tribal partners on the monthly meetings.
That's really great. But while we're convening and we have leadership and people here, it would be helpful for me to know that we're all on the same page and that when the tribal liaisons will be included in this effort, and that regardless of those monthly meetings, I was surprised to get invited to this, and I'm grateful to be here today to listen and ask questions, but I hope that I am throughout this process. Thank you.
Yeah, I appreciate you pointing that out, and definitely we do want your voice and your perspective on this. There was a question regarding how this rate is potentially different than DMAP fee-for-service rates, and they are the response that they are clinically specific encounter rates rather than rates currently negotiated between CCOs and tribes. So there's set rates that would, and part of this, as I understand it, and again, I only have limited knowledge of this, is we've run into situations where there are arrangements where the encounter rate should be met regardless of the contract status between the CCO and the provider. And so we've seen situations where that rate isn't necessarily met based on that contractual arrangement. And so this is one place where we're trying to ensure that what is essentially already a requirement is being met by clarifying it within the CCO contract. We have a Stick, it looks like you have your hand up. Did you have a question or a comment?
Yeah, I would ask that this comes back with more of the stakeholders to discuss exactly how you stated, because there's several different areas that this is touching within here, and I just see the confusion occurring in the chat, and just ask that this comes back to this group. I would appreciate that.
well, I'll offer that up to Jason, recognizing the challenges we had here. If you would be willing to bring this back, we are going to be discussing, or you've targeted to discuss behavior health only items at the CCO Ops Collaborative meeting on the 12th. But Jason, if you'd be willing to come back, that might be an opportunity for us to revisit this more in depth.
Yeah, Dave, and if I could just get clarified, you might be able to clarify this. You all are just trying to make sure. I mean, I see this. I guess I'm struggling because we didn't see any issue, and we've been making these payments, and it's been. I mean, it was never an issue within our CCO. But the goal of this is essentially like the FQHCs, where there's a wrap payment that occurs. Correct? Is that what this is? And I'm sorry if I missed the mark in when you were presenting it.
Yeah, I'm sorry, you cut out for a second there. Essentially, we are in some of those cases we are making up the difference.
Yeah, so that's where I just don't really see this as now I do see us working with the tribes as something that it's not working. It's not like working with another partner. The tribes are definitely something that we have a focus with, but in terms of this payment methodology component, I mean, it's standard procedure, and I guess we're a little confused about, if we are missing something, if we could know, because we feel like we are reimbursing those clinics appropriately, and they're needing what they need to get their wrap payments. So,
well, it looks like we have Will Clark Shim with his hand up. He may be able to enlighten us a little on this. So, Will, do you have something to add? We may be having trouble hearing Will now. Well, I'll commit to, provided that Jason's available to come back on the 12th. We'll definitely bring this back for further discussion to ensure that we're clear on exactly what this includes. I do appreciate everyone's patience and enduring our audio challenges here. And I do appreciate the input. We will take all the input we received, both verbally and in the chat, and we will keep you posted on the next steps here. And I would not be surprised if there are certain aspects of the areas that we discussed. We'll be reaching out again for more input. So thanks again for all of that. And we will be talking to you soon. As I mentioned, the financially specific items will be coming up at the rates work group, and that'll be followed by the behavior health items at the next Ops Collaborative. So thanks again to everyone, and appreciate all your work, and we'll talk to you soon.